I guess we should get started at 6:45. As you all know, I'm not Howard Chansky. I'm here standing in for him because he had a prior engagement as we changed our Grand Rounds dates this month, so I'm just filling in for him. So welcome to the University of Washington Grand Rounds for Orthopedic Surgery and Sports Medicine. We have a great talk prepared by our faculty member, Dr. Nork, and Dr. Christman-Skieller, one of our residents. So we're excited to hear them speak on posterior malleolus and ankle fractures. But before we start that, let me do the monthly shout-outs here. So we have one for Dr. Thomas Burns, some of the staff at Children's Hospital. I guess these are NPs, Laura and Ellen, and they said, "Thank you for always being responsive to questions and calls!" Exclamation point. You have great bedside manner, and we really enjoy collaborating with you to provide the best care for our ortho kiddos. That's a very apropos of children's. Dr. Jimmy Zhu from Dr. Ben Friedman in the emergency department. Dr. Zhu was the ortho consultant in the ED. He came to the bedside promptly, displayed model behavior, both in caring for the patient and promoting a safe educational experience for junior learners. His professionalism and dedication to education is most appreciated by our team. While the ortho residents have a well-deserved reputation of providing excellent patient care, Dr. Zhu's actions go above and beyond. He is truly a model consulting resident. Okay, so that's for Dr. Zhu. Kudos, and thank you for your exemplary service. And then we have two more. Jonathan Kark, one of our PGY4s. This is from one of our attending physicians, Dr. Hagan. Dr. Kark assisted in the care of one of our patients who had a left broken femur repaired at the UW Medical Center. The patient wanted to thank Dr. Kark for his powerful, cogent, and encouraging words. Cogent. And then Janice Olivo, one of our PAs at the University of Washington, who helps us take care of our inpatients. Congrats. Janice has been selected as one of 4 provider recipients. Oh, okay. So this is not a kudos for anybody, any one specific patient, I'm sorry. But she won she's one of the recipients of this spring's UW Medicine Cares Award for UWMC. As you all know, or some of you may know, that the UW Medicine Cares Award was established in 2013, and it formally recognizes and celebrates accomplishments and excellence of those in our community who consistently exemplify the UW Medicine Service Culture Guidelines. And we've had other recipients in this room, so now we have Janice to add to that long list. So congratulations to everybody who got kudos this month, and without further ado, let's get started with our grand rounds. Dr. Christman-Skieller.
All right, thank you, Dr. G. Thank you to Dr. Nork as well for your mentorship on this presentation. I had a very enjoyable and educational time researching for this grand rounds, and I hope that if I use even 50% of the knowledge that I learned these past few weeks, that I'll make a better fracture surgeon. And I hope now that I can share some of that knowledge with you all. These are disclosures of Dr. Nork. I have no disclosures, and none are relevant to this presentation. A brief outline of what we're going to go through in the first 25 minutes of this presentation. We'll go through some quick case examples with an audience poll, so get your cell phones or your laptops out, since I'll instruct you on how to participate in this poll. We'll go through the anatomy of the distal tib fib joint and the syndesmosis, through some classification schemes. Look through the historical perspective, where we might have first learned some standards for fixation, where those came from. We'll look at some of the biomechanics and contact stresses of the ankle joint and how posterior malleolus fractures contribute to this. And then the relationship with the syndesmosis and the effect of fracture fixation on that. And then Dr. Nork will take us through some more literature supporting fixation of the posterior malleolus, the effect on the syndesmosis, and the effect on post-op outcomes. He'll take us through some surgical approaches, and we'll go through some interesting cases of these points, some of which we're now going to look through with this poll. So with your cell phones, for those who have used poll everywhere, you text this number. So your recipient is 22333. And in the body of your text, you're going to add this Claudia Christman-Skieller. And if you're participating from Harborview as well, you can still participate. There's a very slight delay, but we will include you as well. So please participate from Harborview as well. Again, you're texting Claudia Christman-Skieller to that 5-digit phone number. So so we'll let people get involved. And stay awake because we'll go through these cases with Dr. Nork. So first example, this is a 23-year-old male with a fall from minimal height. These are his post-reduction films of his trimalleolar ankle fracture. AP and lateral views. So with these x-rays in your mind, the question is going to be, would you fix this posterior malleolar fracture fragment? So the poll will open up. So you're going to text either A, B, or C to that 22333 number. Interesting. Oh, we're full. Okay. That's okay. Case number 2, same patient, 23-year-old male with a fall from minimal height, same x-rays. Different question, would you obtain a preoperative CT scan of this ankle? Nice to see some variety. So we'll make some interesting discussion. Sorry for the full poll, you got to get your answers in quickly. Case number 3, different patient, 19-year-old male, fell while rock climbing. Also sustained a trimalleolar ankle fracture here in his post-reduction films. So same question as the last question, would you obtain a CT scan of this ankle? I think we're allowed 25 responses per question, so. Yeah. Different patient. So these are serial axial slices of a trimalleolar ankle fracture, showing our posterior malleolar fragment. Question here is, by what approach or approaches would you fix this fracture? Options that you'll see are percutaneous, open posterior lateral, open posterior medial, both of those approaches, or that you would not fix this fragment. So with these shots in your mind, it's odd that it's going so quickly. And that is my fault for using my account and not the UW account, so apologies for that. But I think we'll still get some interesting answers. And then last example here, different CT scan, different patient, but same question, by what approach or approaches would you fix these fragments? It's nice to get some varied answers. Awesome. Thank you all. All right, so to go first through some anatomy of the distal tibiofibular joint and the syndesmosis. These are pictures taken from man's surgery of the foot and ankle. Interestingly, a couple of these ligaments here are actually incorrectly labeled, so I corrected them where appropriate. But showing the ligaments of the syndesmosis as well as outside of the syndesmosis here in anterior view. Here a medial view showing the deltoid ligaments. A lateral view, again, incorrectly labeled. They're actually pointing to the anterior talofibular ligament, so corrected here to show the AITFL. Then a posterior view, specifically the PITFL there on the right. Looking more closely at the syndesmosis, this somewhat simplified schematic of the major ligaments of the ankle syndesmosis, AITFL, PITFL, and the intraosseous membrane. And then I thought these next two slides were an excellent representation of the distal tib-fib joints, ankle joints in the syndesmosis. This is taken from a presentation that was published online by Dr. De Brucker in Belgium. And I found it interesting since we tend to think about many other parts of the body and injuries to them in terms of this ring concept and breaking that ring. For example, pelvic ring injuries, high C-spine injuries. And the ankle joint and the syndesmosis are no different. So here's what he called the greater ring, inclusive of the entire of the entire ankle and subtalar joints. And then in addition, the lesser ring of the syndesmosis. I think what could also be included on this axial slice would be potentially the medial malleolus and deltoid ligaments to create a sort of middle ring. But what's important in these illustrations is not so much the nomenclature or these single break, double break, triple break as we go through injuries to the syndesmotic ligaments, but more so the concept that the ankle joint and the syndesmosis is a ring, and that all of these breaks must be restored for stability of that joint. I wanted to also give some perspective regarding joint surface contact area, especially since we're later going to be looking at how posterior malleolar fractures alter that contact area and contact pressures. So this shows relative joint surface contact area for major weight-bearing joints of the lower extremity, the hip, the knee, and the ankle, showing that the ankle has much less space to work with to distribute the weights of the body. Then looking at some radiographic anatomy. So these are x-rays taken from 3 different patients just to show good examples. On our AP view, some things that we often look at are the tibiofibular overlap. We can also see the intrasura tibialis, or just the intrasura. On the mortise view, we can look at medial clear space, the tibiofibular clear space. And then on the lateral view, seeing the appropriate position of the distal tibia, distal fibula, how they line up on a true lateral of the ankle. And these are, of course, static views that are typically obtained for ankle fractures and, unfortunately, do not tell us much about the stability of the syndesmosis. An interesting paper that illustrated this about plain non-stress radiographs was from HSS. There were 70 patients enrolled. It was purely a radiographic study, and they obtained preoperative MRI to evaluate the ligaments of the syndesmosis, the AITFL, PITFL, interosseous membrane, as well as the deltoid. And they found that there was no correlation between various measurements on static x-rays and the status of the syndesmosis. These measurements they took were the tibiofibular clear space, the tibiofibular overlap. The only thing that really correlated, they found, was the medial clear space widening and the presence of a deltoid ligament tear. But again, not really evaluating the syndesmosis, but is telling us something about ankle stability. So just going through these images, you can see that in a patient with a normal tibiofibular clear space, they in fact had 2 out of their 3 syndesmotic ligaments torn, which could not be evaluated on this plain non-stress radiograph. So they argued for evidence for the fact that static x-rays are not sensitive for evaluating the syndesmosis, the importance of intraoperative stress x-rays, and they argued for the potential role of a preoperative MRI. A classification scheme that we've all seen, the Logge-Hansen classification of rotational ankle fractures, showing the order of injury across the ankle, namely that supination, external rotation, for example, start typically posterolaterally and end medially with a medial malleolus or equivalent deltoid ligament tear. Or for example, pronation, external rotation that tend to start medially and finish laterally with a high fibula fracture. What they called supination, or supination adduction, pronation abduction. And all of these can involve the posterior malleolus. Most commonly, however, are SER and PER injuries. So one of the most often cited classifications for specifically posterior malleolar fractures is this one by Haraguchi, which was published in JBJS in 2006. It's a classification based on preoperative CT scan. So their type 1 fractures, which were the most commonly found, are a posterolateral oblique type fracture, this typical Volkmann fragment. Their type 2s were a transverse medial extension type fracture that extend from the intrasura out towards the medial malleolus. They may have more than one fragment, creating an anterior Chaput fragment based on the size of the medial malleolus and this posterior Volkmann fragment. And then their type 3s were these small shell off the posterior tibial plafond. And they theorized that different fixation techniques may be required for these different types, but it was not within the scope of their study to examine the surgical decision making. They concluded that these 3 major fracture types are present and that CT scan is really the best to elucidate them. However, they did go so far as to suggest that, for example, a posterior medial approach may be required for some of their type 2s. Mason and his colleagues in 2017, then suggested a modification of Haraguchi's classification. They believed it better represented the mechanism of injury, and therefore the associated injuries, and another benefit would be that the increasing type correlated with increasing severity of injury, and therefore would help predict treatment. So their type 1s were what Haraguchi called type 3. It's a small shell avulsion off the posterior tibial plafond. Their theory was that it was an avulsion by the PITFL, and they thought that maybe these would be too small to fix by conventional open reduction internal fixation. However, I would argue that potentially one could think about primarily fixing down the PITFL instead of a syndesmotic fixation. Their type 2s were Haraguchi type 1 and 2 bunched together. The mechanism proposed is a push-off by the external rotation of the talus underneath the tibia. They thought that since it is a rotational injury and not an avulsion injury, the 2As may still have some PITFL attached here on the footprint, whereas the 2Bs would involve the entire PITFL footprint, and therefore it's more likely that the syndesmosis could be unstable, and therefore the posterior malleolus and the intrasura must be fixed anatomically, so that the fibula is here not malreduced within the intrasura. And further, the posterior medial fragment should be fixed first, so that then the posterior lateral fragment can be anatomically reduced. And then lastly, their type 3s didn't really have a true Haraguchi type, and is similar in the fixation techniques to the type 2s, but the mechanism is different in that this is more of a posterior pilon variant with a push-off by a plantar flex talus. And again, worsening severity as the types increase. So to switch gears slightly and go even further back in history, I wanted to try to get to the bottom of the often espoused theory that there is a size or a percentage of the articular surface that dictates need for fixation. 20, 25, 30% are numbers that we've all heard and that have been commonly discussed. The first discussion of this seems to be in this 1940 article by Drs. Nelson and Jensen. It's actually in the journal Surgery, Gynecology, and Obstetrics. This is a figure from their paper. And so they looked at a 5-year period from 1934 to 1939, where they had over 350 ankle fractures in their institution, of which 87 of them were trimalleolar fractures. 10 of them they defined as this classical, involving a third or more of the posterior tibial surface, and 77 they called minimal, involving less than a third. And as they wrote, this was a term coined by Dr. Nelson as simply a convenience in description to indicate different degrees of fracture. So their minimal fractures were all treated with reduction and immobilization with good results. However, there was no mention of how long their follow-up was or how they measured that success. And they stated that not one classical, so greater than a third, trimalleolar fracture was successfully treated by simple manipulation and immobilization. And these instead had to be treated with immediate open reduction and internal fixation. Similar, so Drs. Burwell and Charnley, this is a different Charnley than the John Charnley of hip arthroplasty fame. They similarly thought that if more than a third of the articular surface, that exact reduction was essential. Then they went a little further to say that between a third and a quarter of the articular surface, that these standards relating to the lateral malleolus apply, and those standards are based on a study from 1957 by a Dr. Vassley that showed that the lateral malleolus, if it was 2 millimeters malreduced, patients still got good results, and 5 millimeters yielded fair results. So that's kind of this in-between state. But then if the position of the posterior fragments involved less than a quarter, less than 25%, that they can be ignored. And then lastly, there were multiple studies thereafter, including this one, that showed poor outcomes with posterior malleolar fractures, but none really quantified the size of the fracture. So this study evaluated 142 operative bimalleolar and trimalleolar fractures. These were the results. The top were the simple bimalleolar fractures, and then group 2 is all of the trimalleolar, and they were broken up. So they divided patients with a posterior fragment into those that were less than 5% of the joint surface and those that were more. Those that were less, they didn't fix any of those posterior malleolar fragments. And those that were greater than 5% were split into those that were treated conservatively those that were operated upon. And what they were able to conclude was that any posterior tibial margin involvement did worsen outcomes. So, for example, group 2 here has worse results than group 1. But that those that were treated conservatively fared quite poorly. This large box to the right are poor results for those that were treated without surgery. And they stated that thought should be given to fixation of larger fragments, but again, they didn't really give a specific size or percentage recommended. So then people started to try to study fragment size and to try to quantify a difference in objective measurable outcomes, for example, stability, contact pressures, or patient-reported outcomes. So this was an interesting early study that looked specifically at posterior subluxation of the talus after a posterior malleolus fracture alone versus fracture along with injury to some of the lateral and posterior structures, for example, partial syndesmotic injury. So they looked at cadaver ankles, created increasingly large injuries by increasing posterior malleolar osteotomy size. And then in another group, they divided the capsule, the AITFL, the fibula, and then the posterior malleolus. So on the left, again, only posterior osteotomies. On the right, some of the lateral structures, and then the posterior malleolus was injured. And so they found that only once you had injured these lateral fragments and then above 30% posterior malleolar fragment is when that created statistically significant displacement of the talus. So they concluded that it's not posterior malleolar fractures, but instead injury of the AITFL and fibula in combination with a posterior malleolus fracture that leads to posterior instability of the ankle. However, as we know, posterior instability is not the only thing that we care about with regarding fixation of ankle fractures. We care about rotational stability, I would argue, and that was not examined in this study. However, I thought it was interesting to see the mechanical effect, or rather a lack of effect, of a posterior malleolus fracture alone. So this study took a slightly different angle and seemed to be the first, or seemed to be one to look at specifically contact pressures in what they deemed small posterior malleolar fractures, less than 25%. This was done by Evers and his colleagues in Germany in conjunction with the AO Research Institute in Switzerland. And they looked at 12 cadaver ankles, 6 in each group. They looked at these metrics, and they measured the pressures before and after ankle fracture in 3 positions: neutral, dorsiflexion, and plantar flexion. And then they created bimalleolar and then trimalleolar fractures. They measured, again, the contact pressure, contact area, and the location of the center of this force. Group 1 Haraguchi fractures were created. Type 1 fractures were created. And then they had 2 groups, one in which lateral, syndesmosis, medial, and posterior malleolus were all fixed. Group 2 had only these structures fixed, leaving out the posterior malleolus. The results table is pretty busy, so I summarize here that the contact area they found understandably decreased with fracture from the intact to the bimalleolar to the trimalleolar state, and then went back towards normal once those structures were fixed. And this was in both the bimalleolar and trimalleolar fixation group. And then in terms of contact pressures, predictably, again, they increased with fracture, and then decreased with fixation of the lateral and medial fractures, but then only significantly decreased when the posterior malleolus was also fixed. So this is a very small sample size, however, so we can't put too much stock in statistical significance, but I think it's important to note how contact pressures are altered. In addition, they noticed that the center of force remained shifted posteriorly in plantar flexion when the posterior malleolus was not fixed. So another way to think about it is that in a plantar flexed ankle, without fixation of the posterior malleolus fragment, the talus tended to subluxate posteriorly. So this mechanical investigation shows that even posterior malleolar fractures sized less than 25% do alter pressure distribution within the ankle joint. So we think that posterior malleolus fracture may not affect the contact area, but does affect contact pressures. So how does this contribute to the poor outcomes that have been historically reported? Is it due to the increased load on a smaller portion of the joint? Or is it due to rotational instability? Or due to articular incongruity? So this was a study by Dr. Fitzpatrick from the University of Iowa, that aimed to determine if there were any dynamic stress changes during ankle motion due to posterior malleolus fractures, and if there's any instability. They actually used the same tech scan contact stress measurement tool as the last study we looked at. And instability was measured by a motion measurement system implanted within the ankle joint. They looked at 7 cadaveric ankles, again created some pressure maps that we'll look at next, and measured for each ankle each of these states. They found no evidence of significant instability due to posterior malleolus fracture alone. So they did not fracture the medial and lateral malleolus. To them, that represented an anatomically fixed fracture so that they could focus on the posterior malleolus. But they did concede, and I agree, that this model does not simulate any medial or lateral soft tissue injury, for example, the AITFL. They did nothing to the interosseous membrane. They were focusing, again, mostly only on the posterior malleolus. The important results, though, are regarding the contact pressure distribution. So in this busy graph, intact ankles are at the top, fixed ankles at the bottom. Anterior is the bottom of each of these squares. Medial is on the left side for each of these, as they indicate here. So when in the intact state, the pressure we see tends to shift anterior from plantar flexion to dorsiflexion. When the posterior malleolus is fractured, this is accentuated, and the pressure shifts even more anteriorly and medially. And even after anatomic reduction, the contact stress pattern is still shifted anterior and medial. And so the problem, they argued, with post-traumatic arthritis is not in articular incongruity, but instead in altered contact pressures. This tended to match with what they see clinically, that post-traumatic arthrosis first manifests as anterior and medial joint space loss. So these two studies, the EVER study and this one, have slightly different results, most significantly that the Fitzpatrick study, this one, did not find any posterior instability. But I think that these two studies can be interpreted together to confirm that contact pressures are irreversibly altered, and that post-traumatic arthrosis is probably a combination of anteromedial increased pressures in an area where that level of pressure is usually not experienced, and of some posterior subluxation. So then this might cause us to say, why even fix the posterior malleolus? The damage is done to the joint, contact pressures can't be restored even with anatomic fixation, and the posterior malleolus fracture in isolation doesn't really seem to contribute to ankle rotational or posterior instability. However, we can't forget how reduction of the posterior malleolus fragment might affect syndesmotic reduction. So this is a different Fitzpatrick at the University of Iowa. This was a cadaveric study of 9 ankles. They created small or large Hiraguchi type 1 fractures. And then they CT scanned 3 different scenarios: unreduced fractures, anatomically reduced, and those that were malreduced by creating about a 5 millimeter shim in the fracture space. On the left, the results show that the fibula tends to shift posteriorly with malreduction of large fragments, and that it tends to shift anteriorly with unreduced anatomic and malreduced small fragments. These lighter gray is the small fragments, but these were not statistically significant. On the right, both large and small fragments cause a lateral shift in the fibula within the incisura. So here, shifting laterally. And therefore, they advocate for open reduction of the posterior malleolus for this reason. And then in addition, this study showed that the posterior malleolus does contribute to stability. And the way they measured this was with stiffness, which I thought was a good proxy for stability. This is a study by our former fellow and actually our future chief resident banquet and resident research day speaker, Dr. Gardner. This study, I think, was the best cadaver design in that they created injury to the medial, lateral, and posterior structures, and then studied rotational stiffness. So Fitzpatrick's study that we looked at earlier looked at rotational stability, but without injury to the medial or lateral structures. And then EVER study before that created trimalleolar fractures, but again looked at only contact pressures and area, not at stability. So this was a 2-part study. They imaged 15 of their ankle fracture patients, and then they had a cadaver study of 10 specimens. And they measured stiffness they measured it pre-fracture and post-fixation by measuring the ability of the ankle to resist rotation And this has been a previously validated metric to measure syndesmotic stability. And then the fractures were created in the following order. They sectioned the deltoid ligament, the AITFL, and the interosseous membrane. And then they created a 5 millimeter posterior malleolar fragment, inclusive of the PITFL attachment. The fibula was left intact, so as to focus on the PITFL and the posterior malleolus. However, with the sectioning of the AITFL, interosseous membrane, the posterior malleolar fragment, I would argue that the syndesmotic structures are wide open in this study. So then in the cadavers, they fixed their cadavers one of two ways, either with a syndesmosis, one tricortical screw, or with a P to A posterior malleolar screw. And the results, they found that the group that had the posterior malleolus fixed experienced only 30% decrease in stiffness compared to pre-injury, whereas the syndesmotic group experienced 60% decrease in stiffness. One could say 60% decrease in stability. And therefore, they postulated that posterior malleolar fixation for this fracture pattern may be superior over syndesmotic fixation. And some of the advantages they argued were that, for example, syndesmosis screws can break, you may need a second surgery, and then also that normal tibiofibular motion is inhibited by screws that cross the syndesmosis, whereas posterior malleolar fixation allows normal compliance of the syndesmotic ligaments. This was a small study, a cadaver study, and it was not a prospective study. So now looking back to conclude at what history has taught us, the percentage of the articular surface that we tend to cite seems to be somewhat arbitrary and based on early individual case series. However, we've now learned that the size of the fragment should not really be our decision point, but instead how that fragment and the fracture is contributing to the overall stability of the ankle, in posterior stability as well as in rotational stability. So there are multiple restraints, for example, to posterior subluxation. The posterior malleolus is only one of them. These other structures, the AITFL, fibula, are of course important as well. Unfortunately, however, contact pressures are forever altered potentially in trimalleolar fractures, which may contribute to the poorer outcomes that were historically reported. However, these outcomes are in patients whose posterior malleolar fractures were traditionally not fixed, which is different from some more recent studies, which we'll hear about from Dr. Nork. And lastly, anatomic reduction is essential, not only for restoration of the PITFL length and tension, but also for reduction of the distal tibiofibular joint and the intrasura. And so with that, I would like to turn it over to Dr. Nork, who will take us through some recent literature, some cases, and continue to convince us to consider the posterior malleolus.
Thanks very much, Claudia. What I'll try and do is bring this around a little bit to some of the more recent clinical manuscripts relevant to fixation of ankle fractures. I think the last 5 to 10 years have really changed our overall approach, especially to trimalleolar ankle fractures, and we'll build on what Claudia just presented in terms of our understanding of the biomechanics of the ankle joint. So just as background, what do we know? Well, we know that these fractures typically have a complex morphology, and they're much more difficult to assess just based upon plain radiographs. We know that plain radiographs really underestimate the size of a posterior malleolar injury, so I think we're often led to believe that these are small injuries that may not require fixation. Multiple clinical studies have shown that ankles that have an associated posterior malleolus fracture, for instance, in trimalleolar ankle fractures, have worse overall outcomes. I think Claudia presented nicely some of that historical data that has led to every book chapter recommending somewhere between 20% or 30% or a third of the joint not requiring fixation, and I think that's really poorly supported in more recent clinical manuscripts. We know the posterior malleolus contributes to the stability of the syndesmosis because of the attachment of the posterior inferior tibiofibular ligament, which really provides about 42% of the strength of the syndesmosis. After syndesmotic fixation, I think we have really unpredictable outcomes, and malreductions are relatively frequent. So if we can avoid fixation of the syndesmosis by restoring the general anatomy of the ankle joint, I think that's advantageous. And then lastly, I would argue that if these fractures, intra-articular fractures, were in the front of the ankle joint, we would fix these every time. Yet we're having continued discussions about these articular injuries just because they're in a somewhat less convenient location. So what are we trying to avoid? This is a 56-year-old woman. She was visiting relatives in Arizona. She sustained this injury. These are her original injury films. Then she came back to Seattle where she lives. She was followed up locally. She didn't get referred for about 12 weeks, and this is what she looked like at 12 weeks. And you can see the posterior subluxation. Now, obviously, this is an exaggerated miss for this particular injury, but this creates quite a problem for this patient, and you can imagine what the contact pressures are in this ankle joint. And this also requires a pretty significant reconstruction to get this back to its anatomical location with multiple approaches. Yes, Steve, we did a gastroc slide. This is at 1 year, though, and I think, though, you can still appreciate there's some joint space narrowing that I think is probably related to that delay in treatment that probably could have been avoided with anatomic reduction on day 1. So I'd ask, does fixation of the posterior malleolus matter? Of course it does. And here's a study just from last month. And once again, this came from the group at HSS who's looked at a large series of ankle injuries. They had 178 trimalleolar ankle injuries, and about 2/3 of these underwent fixation of the posterior malleolus. About 1/3 of them didn't have a posterior malleolar fracture, so these were trimalleolar ankle equivalents, but they repaired the posterior inferior tibiofibular ligament. And they had pre- and post-operative CT scans as well as functional outcomes on all these patients over about a 13-year period. Interesting, what they found was that by fixing the posterior malleolus, they improved their results to the same level of those that had a ligamentous injury only that underwent fixation. More importantly, they decreased the rate of syndesmotic malreduction from almost 30% to 10%. And over the course of the study, they changed their practice. And by the last 5 years of the study, the need for syndesmotic fixation in these trimalleolar ankle fractures and dislocations decreased to less than 10%. So here's a case example, and this was case number 3. And about 60% of you said that you weren't going to get a CT scan on this. Now, of course, we didn't show you the injury film. So these were the injury films on this 19-year-old that fell while rock climbing. These are the post-reduction films, and sometimes on a referred patient, this might be what you see. So 60% of folks said that they would not get a CT scan on this based upon these plain x-rays, which I understand. But once you get the CT scan and you look at it and you see how much of the posterior malleolus is involved, this is an intra-articular fracture and involves a significant portion of the joint. I think it probably would yield a different overall treatment approach. So in this case, we positioned the patient prone so that we could get the posterior malleolus accurately reduced to reduce the syndesmosis in the incisura as much as possible, and then proceeded with fixation of the fibula, then put the patient in the supine position for fixation of the medial malleolus. Now this would fall into that less than 10% of cases that despite fixing the posterior malleolus, some of them still have persistent syndesmotic instability on external rotation that you can see from their intraoperative stress exam. And so this particular ankle required additional syndesmotic fixation. So what's the ideal overall approach to patients with a posterior malleolus fracture? Well, I think some of it depends upon the fracture configuration, of course. But a lot of it depends upon what one's overall surgical goals are. Is it to get an anatomic reduction, and does that matter? And what's the optimum fixation strength of various constructs? I would argue that a direct exposure and fixation is going to achieve both of those, an accurate reduction as well as the biomechanically superior fixation construct. So posterolateral exposures, which a lot of you chose to do on case number 4 from the poll, it's certainly a safe exposure. Here's an example. So this is a left lower extremity. Foot is on your left lateral position. We can see is the fibula and the posterior tibia. So there are the peroneal tendons. So working between the peroneals and the FHL, you have access and exposure to the posterior malleolus and the cortical reduction reed that's necessary to anatomically reduce the posterior malleolus. And the complication rate associated with posterolateral exposures is incredibly low. So this was case 4. And we showed the CT scan of this, and we just posed how folks would fix this. And the vast majority, 96%, said they would fix this particular injury through a posterolateral exposure, which I would agree with. And she has a relatively large posterolateral component to this. And you can also see fragments within the fracture line that would block any type of percutaneous reduction maneuvers. Now, in this case, we positioned this patient laterally. Posterolateral exposure allows for first reduction of the posterolateral fragment, then fixation of the fibula. And this fibula was fixed through that same interval, but one could easily go on the other side of the peroneals as well, followed by fixation of the medial malleolus. And this is her at 6-month follow-up. So then the question is prone or lateral positioning, and I think that's really up to the individual surgeon and their comfort level. I think prone positioning has the advantage of a much easier reduction of the posterolateral component of the ankle joint, easy reduction of the fibula, good intraoperative imaging, but then what to do about the medial malleolar structures. Henley can fix the medial malleolus prone. I can't, even with flexing the knee to 90 degrees. So then that requires a second positioning just to fix the medial malleolus. But on more complex injury patterns, perhaps prone positioning is advantageous. For simple patterns, though, lateral positioning allows for a posterolateral exposure of the posterolateral component of the fracture, fixation of the fibula, and then depending upon the patient's hip, can typically externally rotate to fix the medial malleolus in what appears to be a supine position of the limb. Now, what about this strategy for trimalleolar ankle fractures? And this is what I did as a resident. Yeah, we put the patient supine because everyone's comfortable fixing lateral malleolar fractures and bimalleolar ankle fractures supine. Fix the lateral and medial malleolus, then stress the ankle. If it's unstable, if the syndesmosis is unstable, fix the syndesmosis. If there's any residual posterior subluxation or instability, then fix the posterior malleolus. Makes some sense, and then it avoids having to do a posterolateral exposure, which for whatever reason people are uncomfortable with. So these authors looked at that exact approach. So George Russell, we were fellows together, and then Clay Spittler and Matt Graves were both previous fellows here. They're all in Mississippi, and so they looked at almost 200 patients with trimalleolar ankle fractures, and about 3/4 of these, they did just that strategy. Position them supine, and then progressively increase fixation depending upon instability. But then about 1/4 of them, they just went prone right from the beginning, said they were going to go right to the posterior malleolus and then sequentially fix the ankle. And so interestingly, this approach of positioning these patients supine and then just checking progressive instability, they had a 13-fold increase in the need for syndesmotic fixation, right? Only one patient positioned prone required syndesmotic fixation after anatomic reduction of the posterolateral component. And half of the patients positioned supine required syndesmotic fixation, subsequent posterior malleolar fixation, or both. So I think it argues pretty strongly for going after these posterior malleolar injuries and trimalleolar ankle fractures. Now, what about fixation? Fixing them with simple front-to-back screws, which is easy and familiar, versus plating posteriorly. Well, again, a couple of our fellows, Dr. Dykos and Bishop, had looked this up, and no doubt, I mean, it makes sense that mechanically putting a buttress plate on the back is certainly going to be stronger than front-to-back fixation. But like so many things in orthopedic trauma, does it matter? In other words, does that biomechanical difference result in any difference in clinical outcomes? Well, Peter Cole, once again, we were fellows of the same year, they looked this up, and they actually had multiple functional outcome score measures on patients. It was a small group of patients, 27 patients, but 16 of them had posterior buttress plating and 11 fixed with anterior to posterior screws, and they were actually able to detect, even with that small group of patients, improved clinical outcomes and functional outcome scores by anatomically reducing and fixing fixing these through a posterior approach compared to anterior to posterior fixation. And this was confirmed in another study with almost 50 patients, almost equally divided, but the same basic conclusions. Now, there are some patterns that require a posterior medial exposure in addition to a posterior lateral approach, and this is not new. Martin Weber wrote this up 15 years ago. If you can imagine, this is a right-sided injury, patient position prone. This would be more of a classic posterior lateral component. But we see frequently in trimalleolar ankle fractures is this pattern, where there's an associated posterior medial component with posterior medial impaction. And these injury patterns probably require prone positioning with combined posterolateral and posterior medial approaches. So the question is it safe to do those combined exposures? Well, this was a small series that Dr. Weber published, and it certainly was safe in their hands. We've done this hundreds of times, posterolateral and posterior medial approaches, and this is just one patient that came back to our clinic last week, and this was at her 6-week follow-up, and you can see there's still a substantial skin bridge between these particular approaches, and it allows access to both components of those fractures. So this was the first case that we looked at, the 23-year-olds, and less than 25% of folks felt, based upon these radiographs, that they would fix the posterior malleolus, and it was really split 50-50 whether they would even get a CT scan. Now, what we didn't show you were the original injury films, and of course that may change your overall opinion. But what it shows, though, is this extension on the medial side of what you would envision to be a posterolateral fracture. So it extends onto the medial side, and this is consistent with the Martin Weber described trimalleolar ankle fracture variants. And this is obviously an unstable injury with the original ankle fracture dislocation. And this is what you see on the CT scan, of course, is that posterior fracture component wrapping all the way around onto the medial side with multiple small intercalary fragments that may block the reduction. And then there's that separate small anterior colliculus component. And so I would argue that these patterns do need prone positioning, combined posterolateral and posteromedial approaches to allow one to access and reduce the posteromedial component as well as the posterolateral component, and then buttress plating posteriorly, still in the prone position, fixation of the fibula, and then fixation of the medial malleolus, and this is that patient at 6 months. So one could argue, why not fix every posterior malleolus fracture? And I don't think I could argue against you. I think there's definitely logic to support that. There are clinical studies to support it as well as mechanical studies. Even small capsular avulsions perhaps could benefit from fixation because of reestablishment of the posterior tibiofibular ligament and its relationship with the syndesmosis. And so we'll end with one last case, and this was case number 5. So these were the original injury films on this patient who had a trimalleolar ankle fracture dislocation. These were the post-splinting radiographs, and I think you can see the posterior malleolar injury. When you look at the CT scan, it certainly involves a small percentage of the articular surface, but it does involve the entire posterior aspect of the ankle joint. So just for you to ponder, would you fix the posterior malleolus after this discussion? How would you position the patient? What would you fix first, second, third? What implants and principles would you use? And do you think the syndesmosis will require fixation if you've fixed these components? So we did start with prone positioning on her with combined approaches that let us buttress and fix the posteromedial and posterolateral components, fix the high fibula fracture, and then finally fixing the medial malleolus, stressing the ankle joint. This is that patient at 3 months and then at 3-year follow-up. So I think in summary, I think you should strongly consider CT scans on all posterior malleolar fractures associated with trimalleolar ankle fracture or fracture dislocation so that you understand both the size and the configuration. I think we realize that there really are no size requirements that guide fixation, and perhaps we should stop looking for excuses to not fix the posterior malleolus and assume that we're going to fix the majority of these. Fixation for intra-articular fracture certainly gives an accurate articular reduction. It reconstructs the posterior inferior tibiofibular ligament. It reconstructs the incisura to decrease the rate of syndesmotic malreduction, and it reconstructs the strongest portion of the syndesmosis. I think we do want to fix these from posterior to anterior whenever possible. Clinical outcomes after an accurate fixation really does restore these ankles to those without posterior malleolar fractures, and I think it really decreases the need for syndesmotic fixation. Thanks very much. We'll entertain any questions. Dr. Hansen.
I don't have a question so much as a comment. I think this is absolutely great, as I expected why I dragged myself out here this morning. But as some of you know, I started here a long time ago, and by the time I was ready to quit doing trauma and being on trauma call, it was about in 95. I don't want you to think I quit early, because I was 60 then. But I had already decided that fixing all posterior malleolus fractures was an important thing to do. But I became much more convinced, because the reason I quit is because of Frank Alvine, who's another member of this old residency, a couple years behind me, had developed a total ankle, and I started doing total ankles. And as soon as you start seeing all the back x-rays of people who had total ankles, there's a lot of posterior malleolar fractures. So it's a major cause of late arthritis in the ankle, which confirmed the idea that I had that you should fix every single posterior malleolus. And I'm delighted that that's basically what you came up with. Because I think it's tremendously important that and I feel what it does is it controls the anterior posterior shifting of the talar head, or not the talar head, but talar body. Any shifting in that area is going to be unacceptable and cause arthritis. So it's kind of a no-brainer, I think, which again you pointed out beautifully, that fix those things. And fix everything that goes with it that you can easily fix. Because the ankle has a very specific anatomy that gives it the function that it has, which is wonderful function if you consider all the things your ankle does for you. As soon as you lose some of that, you will miss it. So anyway, all I can say, not ask a question, just confirm that I think that what you just told us is absolutely right on. Thanks.
And Ted, thanks a lot. And I think Claudia and I both have to really give credit to you and Steve. I mean, we've been hearing this. I've been here for 20 years, and yeah, from you all, we've been hearing the importance of it, but because you all see these patients late. But it's easy to kind of discount, oh, you're seeing the patients that did poorly. There are a lot of posterior malleolar injuries out there unfixed that are doing great. You're just seeing that particular group of patients. And Steve has been jumping up and down for a long period of time saying we need to fix these. And finally, 20 years later, the literature I think is really catching up, because I think it's really convincing in the last 5 years, looking at even short-term functional outcomes that are significantly improved. And I think the long-term studies will confirm that as well.
One thing I'd add, Ted's points are that, when I was in training, I saw articles in JBJS saying that posterior malleolar injuries didn't need to be fixed, and there's, in black and white, it didn't need to be fixed, and they did fine, whatever that meant. And then I started seeing what Dr. Hansen was talking about, and more recently, I think it's indicative of when you look at the stability that you get of the posterior malleolus, that clearly provides not only the PITFL, but a lot of the structures that go along with what you mentioned in your talk about the whole ring of the ankle. And what you have to sort of think about in providing stability of the ankle, we can only provide as orthopedists bony stability of the structures that are involved. So if you fix the fibula, fix the posterior malleolus, those are all bony injuries that you're treating. But what you're not really able to treat is the capsular injury that is inherent with all of these, especially all the dislocations. So every one of these has an anterior capsular disruption. Many of them have a complete deltoid disruption. And whether you agree to repair the deltoid or not, clearly, if you fix the bony components of the injury and then can provide stability by something to push against the talus, against the reconstructed posterior anatomy, you can then provide a stable ankle. And what happens is if you don't, we just did one yesterday, you fixed everything that you think is right from a body standpoint, and there's still instability of the ankle on the medial side. And that's, I think, the big take-home is that, and I just caution everybody to look at the final radiograph of an ankle. If you look at the lateral radiograph, weight-bearing radiograph, the limb should be in at least neutral, if not dorsiflexion. Exceedingly hard to do in many of these injuries because every one of these injuries, and it's more observational that I've identified it, but it's all a continuum. Every one of these people has significant equinus. That's why the injury occurs. So everybody with a posterior malleolar injury, a syndesmotic disruption, any kind of injury of that significance, they all have significant equinus of their gastroc. So that contributes to the instability that progresses if you don't address that as well. So it's kind of a continuum of all of these, but a very good presentation.
Yeah. And I do think, to your point about, other soft tissue injuries, someone will be doing a grand rounds in about 2 years supporting, I will bet, operative fixation of deltoid ligament injuries in trimalleolar ankle fracture equivalents that don't have a metamalleolar injury. Obviously, there's some evidence coming out to support that, which refutes older studies that says you never have to fix the deltoid. But perhaps anatomic reconstruction of all the soft tissue elements of the ankle will eliminate the need for 98% of syndesmotic fixations. Thanks, everyone.